Okay, well, thank you for the kind introduction. I'll start off and on behalf of my colleague Katja and I, we would like to thank this opportunity to share with you our thoughts on end-of-life decision-making, especially about shared decision-making in this case. It has been, or this question has been occupying our discussions over the last few years, and so we're looking very forward to have a discussion afterwards. Before we start off, I'll start off and hand over then to Katja halfway through. I would like to give you some background information why this is relevant for clinical neonatologists. So before starting off, I brought some data to clear up the relevance. And I brought up the data from 2020 in Germany. In 2020, Germany's population counted for 83 million people. And of those 83 million people, 980,000 persons died. Well, fortunately, only 0.4% of them were children. But when we take a closer look at this pediatric group, 46% of them died in their neonatal period. And this means that for among pediatricians, the neonatologist most frequently encounters death and end-of-life decision-making, especially compared to their other pediatric colleagues. Well, the majority of newborn infants do not die despite extensive resuscitation, but most of them die after a decision to withhold or withdraw intensive care is made. And over the last decades, parents are increasingly involved in this decision-making process, and medical societies in various countries recommend shared decision-making as the most appropriate decision-making approach for such decisions, and the German guidelines explain their recommendation with one of the arguments that parents prefer to be involved. There are various reasons to argue for and against parental involvement in end-of-life decision-making in neonatology. Well, in general, parents are considered to have the moral authority to make decisions in their child's best interest. They may be best placed to know what is what are the interests of their child because of their closeness to their child and their special bond. And this bond begins during pregnancy and develops over time. Well, parents should be involved because in treatment decisions, because there are lifelong consequences, of course, of these decisions. They will be responsible for ongoing physical or emotional, medical, but also financial care for the child when it is, for example, survives with serious disabilities. On the other hand, they will also have to live with the consequence when there's a decision made to forego intensive care and the child dies. Empirical research showed that parental involvement in end-of-life decision-making may be associated with lower grief scores, less grief, and those who felt that they had shared the decision-making report a lower decisional regret. Well, on the other hand, when a child is critically ill and a possible decision to forego intensive care has to be made, obviously parents are in a psychological so-called crisis, you can say, and some say that their emotional involvement in the case and feelings of guilt and possible lack of medical knowledge may disable them to even participate in decision-making. And on the other hand, parents have to live with the consequence for the decision to forego life-sustaining treatment, which may cause feelings of guilt and feelings of that they feel responsible for the death of their own child. In the end, we do not aim to argue whether SDM is good or bad. We just aim to analyze whether guidelines should prescribe shared decision-making for this particular situation in end-of-life decision-making in neonatology. In light of these facts, it can be stated that end-of-life decision-making is a clinical relevant topic for neonatologists, and parental involvement in end-of-life decision-making is complex. And neonatal guidelines aim to serve with guidance for neonatologists, but there are a few aspects in the guidelines that need attention before we can continue and answer this question. Neonatal guidelines mainly focus on one particular patient group within the neonatal field, namely premature babies born at the border of viability. But not all neonates that die are premature babies. And the rest of the group can be attributed to two great groups. One is congenital babies with congenital malformations, for example, trisomy 13 or 18. And another big group is those with acquired disease or damage, for example, perinatal asphyxia or severe sepsis. As specific guidelines for these two groups are lacking, the guidelines that focus on end-of-life decision-making for premature infants in clinical practice mainly serve as guidance for the other two groups as well. This is not what they are meant to be, and those groups are not identical, especially decision-making situations can arise at different time points. For example, during pregnancy, so prenatally, around birth, so perinatally, and postnatally. And for the patients in different groups, there are variable time points in decision-making, and in case of prematurity, it can be decisions about starting or foregoing intensive care, as well as prenatally the decision to start antenatal steroids, which improves outcome. And for patients with or infants with lethal congenital malformations, a prenatal decision can be to continue pregnancy and provide primary palliative care after birth, as well as termination of pregnancy. Furthermore, besides getting clear for who the end-of-life decision-making can be considered, the guidelines try to offer some guidance by describing when end-of-life decision-making can be considered. And for infants in the so-called gray zone, continuing intensive care as well as palliative care are considered two equal options. And in case of prematurity, the guidelines describe a gray zone by using specific borders of gestational age, often combined with estimated birth weight cutoff. And the German guideline, for example, uses the estimated birth weight of 400 grams as an additional factor. And as you can see here, there are substantial variance among countries where they set the borders of this gray zone. This way of defining a gray zone is as you can see, only applicable for extreme premature infants. Another way of understanding the gray zone is depicted here. And here the gray zone is actually orange and describes a setting in which there is a situation of equipoise. At one end of the spectrum, the far right, there are cases in which one expects high chance of survival with good quality of life, and the benefits of intensive care outweigh the harms, and there is a favorable prognosis. And at the other end of the spectrum, the far left, there's a high chance of dying, and when the child survives, there will be poor quality of life, and the child will endure suffering, and this will be framed as an unfavorable prognosis. And in between, there are cases in which the best management of health problems is not necessarily evident. Evidence for effective action might be weak or lacking, or clear options may be available, but differ in terms of outcome. And the choice for such outcomes will then depend on the values that parents attribute to certain outcomes. And in such cases, one can speak of a situation of equipoise in infants in this gray zone. Both continuing intensive care as well as foregoing intensive care are options. So as we've taken a look now at what the guidelines are made for, what they're aiming at, and what they try to serve in terms of guidance, I would like to come back to our question. And should neonatal guidelines prescribe SDM for this particular decision-making situation? And that's where I would like to hand over to Katja.
Thank you so much. And our answer to that question is actually no. And it is no, because it depends a lot on how you interpret the norm of shared decision-making, whether you consider shared decision-making to be an umbrella term for a broad spectrum of possible collaboration or a specific form of role allocation. And either of these options is not recommendable in the case of end-of-life decision-making for neonates in very critical situations. So at first I will try to explain the first option, why we think it's no when SDM is considered to be an umbrella term for collaboration, We think that version is too vague to be helpful for neonatologists and not necessarily beneficial for the involved parents. And if you take a look at the guidelines and see how they portray their recommendation or their prescription, they talk of parents and the healthcare team working together. They should both inform a joint decision. The parents must be involved, or even more specifically in the German guideline, the dialogue between physicians on the one hand and parents on the other hand, where there's a certain understanding of a role that the physician has rather the role of a medical expertise, and the parents have rather a role of bringing in the values. These gives you like an idea of an approach to decision-making. And only the Canadian guideline here is going so far to say shared decision-making is the best approach for preference-sensitive decision-making. So proponents of shared decision-making sometimes contrast shared decision-making against two options which are not favorable. And what you can see here in this picture is these options that are not part of the collaborative approach. And on the very left side, you see medical decision-making without the parents. But if you consider cases in practice in neonatology today in industrialized countries, and for example, in Germany, it is very rare that neonatologists and other involved physicians would make a decision without informing the parents about the decision-making process or the therapeutic options. Maybe that could be the case if a mother loses her decision-making capacity during labor and the father is not available and there has been like an emergency that wasn't foreseeable. But other than that, it's very unlikely that neonatologists do not involve parents in the decision-making process. It's legally codified. The parents have, in many countries, the right to make substitute decisions for their children in a certain frame of considering the best interest of their child. So that's very rarely imaginable. And on the other side, outside of the spectrum of collaborative decision-making, is parental decision-making without the medical team. That's also very rare. You could maybe consider cases where there has been like a very devastating diagnosis and prognosis, and parents early on decide to take a palliative care approach and deliver the child at home and then accompany the dying process of their child at home. Or maybe you consider a case where parents take their child and leave the neonatal intensive care unit, but these cases are very rare, and parents could, for example, in some cases be challenged with legal consequences with reference to the best interests of their child. So in practice, most of the cases that neonatologists deal with fall within the spectrum of possible collaboration. And we would like to differentiate this spectrum a little bit further. So if you differentiate this spectrum, and in our model, the green space, like the ramp, is highlighting the increasing involvement or the increasing participation of parents in decision-making. On the very left side, the first area of collaboration, we call the parent-informed medical decision-making. And in this area, the values of the medical team are guiding the end-of-life decision-making process. In the area on the very right, that's the area we call medical-informed parental decision-making. Here, the parental values foremost are guiding the decision-making process. Parents could, for example, be informed by doctors about the available treatment options, and if necessary, doctors would implement the decisions of the parents without further deliberation. And in the middle, there is this realm, this area where both parties could collaborate intensively to determine the decision together in a deliberative process, which then could be guided by the shared values of both parties. And here, different levels of the extent of sharing are possible. And at least opposed to the other two areas. In this area, it entails a joint decision-making conversation that is open, that doesn't start with a recommendation by the medical team or a partial decision by the parents. And the proportion with which the medical team or the parents could feel responsible for the decisions within the spectrum of collaboration could vary. You could think rationally that maybe if you are less involved, you feel less responsible for a decision, for example, and then the consequences bear less heavily on you. You might feel less guilt. But in our empirical research, we found that's not necessarily the case. For example, it could be that a doctor suggests a decision-making strategy and a decision that is 100% in line with your demands and preferences, and then you only express your agreement with it, but it could feel like absolutely your decision. So it's not necessarily the case that if you are further on the side of the parental values, that parents feel more responsible than on the side of the medical values. And now we would like to add another layer of complexity to this model, because we would like to introduce decision-making models. And decision-making models are different from a decision-making approach. They entail certain role allocations, certain steps, certain tasks of a decision-making process. They are practical, they are more methodological. And we have identified 4 exemplary models for end-of-life decision-making out of a qualitative research synthesis. So the models that we would like to highlight here, they have like an empirical basis, but we retermed them, we rephrased them. So it could be that some of the phrases are not something that you're already familiar with. Here on the very left side, we start with the tacit approval model. That's a decision that is made by physicians alone. There is no explicit parental agreement with the decision, but an implicit agreement. So the doctor informs the parents constantly, and the parents, by not objecting, by moving along with it, they give their tacit approval to the decision that is made. The next model that you could think of is the recommendation acceptance models that has been, for example, described in a study by Hendricks et al. It entails a process of finding a recommendation in the medical team that is indirectly informed by parental values. They communicate the option to the parents, and parents can consent or veto to it. There is no open conversation about parental positions, doubts, or values in the meetings. It's doing justice to the informed consent doctrine. And the shared deliberation model, that's a model that I will explain in more detail later when we look at the SDM as a narrow concept understanding, but it entails a shared deliberation between the two parties that are in reference to each other. So it's not like one places one argument and the other places the other argument. They are trying to put these together. And the last model that you could consider is the informed parental decision-making model. It entails the medical facts are given by a physician, then the deliberation and the final decision is conducted by the parents alone. There is no discussion of values in the clinical encounter. At best, the parents give their justification for their partial decision, and then this decision is implemented. If in doubt where to put your model on the spectrum, you can ask yourselves, who is it or whose values are guiding the decision at the moment? And is it the values of the medical team? You'd rather place it in the realm on the left side. If it's the shared values or the values of the parental team, you could place it in other spectrums. So if you understand shared decision-making as an umbrella term that includes all of these possibilities, it's not really helpful if you are confronted with a single case. And that's what these guidelines are for. They should help neonatologists navigate difficult decision-making encounters in specific cases. So we think, if you understand it as an umbrella term, it neglects the differences that are or can be of ethical value when deciding for a specific model of decision making. These models could be differentiated in terms of their power relations, in terms of their sense of responsibility that people have if they are involved, and they could also matter in terms of feeling of guilt. So like important ethical values are neglected if you understand it as like a broad concept. And as I said, if neonatologists are confronted with a case like an extreme premature infant at the gestation age of 23+3 and additional complications with an uncertain but potentially severe prognosis, or if you could be confronted with parents who have like a low level of education, who have like language difficulties when they try to express themselves, like there could be context relevant aspects that could be important in terms of choosing one of these models. And that's something that we can look at in the when we look at the next possibility. But in summary of that first step, we don't think SDM should be prescribed in neonatal guidelines for end-of-life decision-making if they are understood as an umbrella term, because then it's too vague to be helpful for neonatologists and not necessarily beneficial for the involved parents. It only affirms an approach that is already legally regulated, widely accepted, and doesn't tell you how to perform end-of-life decision-making, because it can regard to various options of organization of the decision-making process. So then what about the next possibility? If we understand SDM as a specific form of role allocation, and that's also a possibility that you can encounter when you read about SDM, that researchers and experts understand it as a narrow concept that entails certain steps and certain options what you could do. And what you see here is a model, a framework that has been developed by De Vos et al. Miriam De Vos is a medical psychologist and research associate at the Amsterdam University Medical Centers. We have collaborated with her in ENFoLDING, and she has been applying this model in a qualitative analysis to natural conversations between the medical team and parents of patients in pediatric intensive care units. So it was applied in pediatrics, but not yet in neonatology. And through this research project, she even specified or operationalized that model further. Here you could understand that model as going, the conversation is going in 3 phases. Phase 1 is the discussion of the nature of the decision and an exchange of information of both parties. Phase 2 is a shared deliberation, an exchange of values and preferences that is related to each other. And phase 3 could be the parental choice, or even a consensus, a joint decision between parents and physicians. And if we take a closer look at the deliberation phase, which is for the ethical perspective of uttermost importance, she described even more specifically steps like asking which role parents would prefer in the decision-making process, providing information about the role that is preferred, asking what values and preferences are present, providing information about values and preferences. So you see it's like a back and forth between the both parties, expressing objections to the other's preference, inviting to express emotions, etc., etc. So we applied her framework to a sample of 12 conversations that naturally occurred in the NICU at one of the NICUs at LMU Hospital. And you can recognize the steps that I just presented here on the left side. And here you see it's either a conversational act that is started from the neonatologist to the parents, or from the parents to the neonatologist. And then we took a look at the transcripts of these conversations and recognized how often these steps are taken in this conversation. And you can see it is conducted heterogeneously, but none of the cases conducted this approach to shared decision-making to a full extent. We concluded that SDM in this context has been conducted to a rather limited extent. And of course, this raises questions of why is there not this form of decision-making? Is that a good thing or a bad thing? Should we now teach neonatologists to do better? Better meaning to be more coherent with this idea. So to get a first impression of how to evaluate that, we subsequently interviewed the parents that were involved in that conversations and asked them to evaluate themselves how they experienced the end-of-life decision-making process. And we learned a lot out of this interview study, and I just want to share some of the learning points that are now relevant for our questions: should guidelines prescribe shared decision-making? So the first thing that became very clear to us is that SDM as a narrow concept is like a very high demand on decision-making, and both parents and neonatologists have to be willing and capable of sharing the decision-making process. And most parents appreciated the decision-making process that they experienced and judged it as a collaborative process that was beneficial to them, regardless of the decision-making model, regardless of whether it was only shared decision-making to a very limited extent. And those who prefer other models, and we also see that in our qualitative literature synthesis, those can either prefer more or less participation. So sometimes proponents of SDM only provide the data for parents want to be more involved, or provide only the data for parents want rather shared decision-making than making decisions on their own. But it can actually be both ways. So there has to be kind of a fit of the decision-making process and the parents that should be involved. And the neonatologists could be forced by such a guideline to overburden parents and to overburden themselves, and that could also raise ethical objections. So in summary, if we understood shared decision-making as a specific form of role allocation, it is too narrow to allow neonatologists to act according to their ethical responsibility towards the parents, but also towards the child. It restricts the decision-making process to only one form of collaboration without being able to adjust to consider case-based attributes of ethical value in the choice of the decision-making model. So we do not only want to criticize guidelines, we would also like to offer them an alternative to what they are doing right now. The first thing we would like to highlight is we should give up the term of shared decision-making in these guidelines, because it could be understood in both ways, and then it creates a lot of confusion and maybe false interpretations. Guidelines should be very clear whether they mean collaborative decision-making as an umbrella term, or a shared deliberation model, etc., as a specific model approach. And then we would prefer guidelines that give you a realm where you could choose between many options and have like guidance on a preference tailored and context sensitive approach. And those guidances could, for example, highlight important criteria that help neonatologists to decide which model is best justified in certain cases, and potential criteria that could be considered, especially if you want to write a guideline that is not only focused on prematurity, but on all cases where end-of-life decision-making can be considered, the condition of the child, the expected prognosis, and of course, the parental preferences for decision-making. Thanks for the opportunity to give you an impression of what we are thinking about. I'd love to hear about your comments and maybe suggestions, and maybe we're on a wrong path. So let us know your criticism. And of course, we appreciate not only the funding that Esther received during the project, but also the collaboration with Florentine and Petsy that helped us a lot during the last 4 years.